month. Dates are going to come in few weeks. All of them, the centers and everything is being finalized. In about 2 to 3 weeks, practicals would start. So I thought that since you had a case presentation, there are many other things which needs to be covered. The thing about case presentation is usually you're able to do one case presentation in one time. But there are many other points which you need to know because you have 4 cases on a given day and a lot of discussion. So particularly for today's topic, what I did is I myself selected important case scenarios, about 7, 8, and I've added what is more important in 3, 4 slides so that we can initiate a practical discussion. And I let you know as an examiner when I go. Just now I came back as an examiner. What are the points which you need to cover? So I have made a case capsule relevant to surgical oncology practical exam, and I can tell you that what can be covered in this, and you need to answer. The first case capsule I have made is on early breast cancer. You can see that it's a 56-year-old postmenopausal lady. There are no comorbidities. And then she noticed a painless lump in the right breast since 3 months. So it's a recent onset. She does not give any history of nipple discharge, nipple retraction, breathlessness. When somebody asks what are the causes of nipple discharge, you always classify it as unilateral, bilateral, pathological, physiological. Physiological content in physiology, that is milk. Physiological content in pathology, that is galactorrhea. Pathological content in physiological and pathological content in pathological. Clear, watery, serous, unilateral discharge in a perimenopausal or postmenopausal has 50% of chance being a breast cancer. Clear, watery, serous, unilateral in a elderly lady. Commonest cause of blood discharge of nipple is papilloma. Chance of breast cancer in that is less than 1%. Okay, remember these things. So, and then if you have a periductal mastitis, then it is an anaerobic mix. So, usually a mixed antibiotic like tinidazole has to be given. So, this lady has no features of systemic metastasis like breathlessness, bone pain. She is para 2, living 2 with no significant neither hereditary breast cancers or family breast cancer. You know, P53, Lee-Fromeni syndrome, HBOC panel, all of them. Now, if you see the photo there, she has a 1.5 into 1.9 centimeter lump in upper outer periolar area of the right breast. Nipple areolar complex normal, no retraction, because we all know that the skin puckering is ligament of Cooper. The nipple inversion actually is the lactiferous duct involvement. And other breast is normal. So it may be unlikely to be lobular or hereditary breast cancer. Now, if you see what is the way, this is the mammogram. Remember, mammogram actually is 3 views, but for convenience cost sake, we take 2 views, mediolateral and craniocaudal. Mediolateral also is tilted a bit, so you have an oblique such that the axilla is covered and the pectoralis muscle and the breast interface is seen. So you can see that it's a solitary lesion. No microcalcification in the other part of the breast, no lesion in the other part, no architectural distortion other than this lesion, no multicentricity, no multifocality. There are 2-3 definitions of multifocality. One is multiple lesion in the same quadrant, or if the lesion is 2 centimeter within the 2 centimeter multifocality. If it is more than one quadrant, it is multicentricity or more than 2 centimeter. However, this also depends very clearly on the cup size of the breast, A cup, B cup, C cup. So, triple assessment, clinical examination, imaging, which is mammography in elderly and sonomammogram in younger, and both combination of sonomammo and mammogram. Core biopsy to be done, not FNAC, you know that, and ultrasound of the axilla. She had an infiltrated ductal carcinoma, grade 2, estrogen receptor positive, progesterone receptor positive, HER2 negative, Ki6750. Remember, in old time, receptor assessment was done in activated charcoal system, which missed a lot of estrogen receptor. Now it is done by IHC Aldrich score. HER2 can be done from blood or from the tumor. It can be done by IHC or it can be done by fish. If it is 2+ and up 2+, then you do by fish. K67 ideally less than 10% is more favor of luminal A. 10 to 20% is a gray area. About 20-30 is definitely luminal B. So now what are the questions that can be discussed in this patient? What are the absolute contraindications for breast conservative surgery? And what are the level of oncoplasty which is going to be asked in exam? Remember, BRCA1, BRCA2 is not absolute contraindication. Students actually think that BRCA means double mastectomy. No, it is not an absolute contraindication. It may be a relative contraindication in addition to other. Second, central quadrant tumor, not a contraindication. Nipple areola lesion, not a contraindication. Okay, age, not a contraindication. Now we will discuss about these two practical aspects. Next question is, in this lady, see that we can do a technique where you can see what I have shown. There are two types of local oncoplasty: volume displacement, volume replacement. Volume displacement means if less than 30% of breast tissue loss is there, you use a glandular flap of the surrounding breast and you just displace and suture them. If it is volume replacement, that means there is more than 30% but less than 60%. So that then you have to take it from a perforator flap, L cap, I cap, or other places, or maybe mini LD. So three questions in practical. Fourth one, name the following oncoplasty procedure. So look at this. This is one oncoplasty name. This is another oncoplasty. So now we will discuss all the answers for this. Okay. The next question is, this patient underwent breast conservative surgery with sentinel lymph node biopsy with a volume displacement oncoplasty. Final report came as T1, N0, M0, margin clear. Name any three genomic profiling, and if you use Oncotype DX, RS score, what is RS score, what score below is low risk, and what is the molecular classification. So, I'm going to cover number one, absolute contraindication for breast conservation, levels of oncoplasty, name of this, and then genomic profiling. These are all practical questions. Now I'll answer number one. What are the absolute contraindication for breast conservative surgery? Multicentric disease with two or more primary lesions in separate quadrant of breast such that you cannot remove them in single incision with a good cosmetic outcome. Multifocal is not a contraindication. Remember this. Diffuse malignant microcalcification all over the breast seen on mammogram. Absolute contraindication. History of prior therapeutic radiation. Patient had a lymphoma or had lung cancer. So there is a therapeutic radiation to that region given. You can no longer give radiation. Pregnancy first trimester. So you can do breast conservation, but you cannot give radiation later because woman, 9 months you are without radiation, which is difficult. You can give chemo and then come back and do breast conservation in last trimester, then give radiation after the delivery. Then persistent positive margin. You do a margin revision, frozen, it is positive. Second time you revise, it is positive. Or you have done a cavity shave and it comes positive, then you go back and revise and second report comes positive. So these are the absolute contraindication in exam, you can say. Rest all is relative. BRCA is not, central quadrant is not, multifocality is not, size is not. You can give neoadjuvant chemo, downsize and still do breast conservation. I hope this point is clear. Question number 2. What are the level of oncoplasty? This is called as Krishna claw level oncoplasty. Krishna claw. Volume displacement, volume replacement. Volume displacement, level 1 Krishna claw oncoplasty, level 2 Krishna claw oncoplasty, level 3 Krishna claw. Level 1, less than 15% breast tissue moved. Level 2, 15 to 20. Level 3, 25 to 50. Beyond 50, you cannot do volume displacement. You need to replace it. Either LD, perforator flap, or tram, or a diap, or anything. Now, if you see this technique which I showed, this is a round block Benelli. This is called as round block, double down at round block Benelli oncoplasty. This is called as Griszotti. This is done when you have a retroareola where you have to remove the nipple areola, but you can form a new nipple areola. You can see that inverted comma T incision. So that's why nipple areolar lesion central quadrant is not a contraindication. Benelli round block double donut technique, Grissotti flap. Okay. So this is what I have written here: Benelli round block, Grissotti or inferior dermoglandular flap. Next question: name 3 genomic profiling: Oncotype DX, EndoPredict, MemaPrint, PAM assay. It is also called as ProSigna. Any 3 remember: Oncotype, EndoPredict, MemaPrint, ProSigna. It's also called a PAM 50. Now, if you use Oncotype, a RX score, okay, of less than 11 is counted as low risk. Please remember this. This is asked in practical exams. Next, write the molecular classification of the breast cancer: luminal A, luminal B, HER2 new enriched, basal like, triple negative, Claudin, low breast cancer subtype. Okay, so these are the genomic profile. I hope it is clear, because in the given time I can't cover too much, but this would sail you through most of the exams. Most of the questions centers around this in early breast cancer. Now I'll go to a case capsule on head and neck, because remember, breast, head and neck are very, very bread and butter. You need to know. Next is a case capsule I have prepared for you on head and neck cancer on a oral cavity. A 55-year-old male, tobacco. You must know, smokeless or smoke. Reverse chutta forward. Keeps in the mouth in the GB sulcus or swallow. The malignancy is related to cigarette. Cigarette is lung, stomach, cervical cancer, bladder cancer, renal cell carcinoma, upper aerodigestive tract. There are many, but in this order. Like, we always say renal cell carcinoma etiology is 3 C's, CCC, cigarette smoking, cadmium, working in aniline, dye and chemical industries. Another C is Van Ippel-Lendu syndrome, that is a congenital. 3 C's. Okay, remember this. Renal cell carcinoma is the only tumor which is so aggressive that it can metastasize in another tumor. A guy who is a smoker develops renal cell carcinoma. He also develops a bronchogenic carcinoma in the lung. In the bronchogenic primary carcinoma of the lung, a RCC can go and metastasize. In the human body, the only tumor which is aggressive enough to metastasize inside another tumor, RCC inside the bronchogenic carcinoma. Remember this. So, 55-year-old male, tobacco chewer, no comorbidity, complaints of non-healing ulcer in a oral cavity. Look at the way I have put the history. Try to put it smoothly in exam like this. On the same side of the tobacco chewing, with recent onset of difficulty in mouth opening, then you must know the trismus. Now look at this. There is a trismus grade 2, 4 into 3 centimeter lesion in the anatomical subset of oral cavity as shown in the clinical picture. Left neck has 2 into 1 centimeter level 2 node palpable. A punch biopsy from the edge taking care of the lesion and the normal area full depth shows moderately differentiated squamous CA. Remember, it can be keratinizing, non-keratinizing. Keratinizing means it is where there is a skin, that is a penile cancer, vulval cancer, and then epithelial cancer of the skin, squamous cell carcinoma. We also call it epithelioma. Where there is a mucosa, where there is no skin, it is a non-keratinizing squamous cell cancer. Okay, now the question. Identify this anatomical subsite, define the boundaries of the same. Second, in this patient, what are the most likely cause of recent onset of trismus? Long chronic onset may be secondary to submucous fibrosis, but recent. Okay, so anatomical subsite and what is the cause. Next, look at this CT scan. On the left side, you can see that there is a big lesion on the left side where I put an arrow. What are the boundaries of infratemporal fossa? Remember, in head and neck cancer, the working horse investigation is contrast enhanced CT scan. However, MRI is used in selected cases like paranasal sinus tumor, maxilla ethmoid, skull base tumor. When there is an extension into infratemporal fossa, early laryngeal cancer to know the T status into the paraglottic and pre-epiglottic space involvement, and base tongue tumor, and deep lobe of parotid. These are the places where MRI is preferred. Okay, MRI doesn't show nodes so well like CT, and CT scan shows cortical bone mandible erosion very well. Cartilage erosion is shown well in MRI. Lymph node evaluation is shown well in CT scan. Perineural invasions of tissues, MRI. So everywhere CT scan except those 5 subsets I told in exam, you must say MRI. Next question. What are the types of marginal mandibulectomy and what are the absolute contraindication for marginal mandibulectomy? Look at what I have drawn there, types of marginal. Okay. So these are the question we'll address. Question number 1. So what is this anatomical subsite? It is called as retromolar trigone, RMT. The anatomical boundaries of the retromolar trigone is it's a triangular area of mucosa overlying the ascending ramus of the mandible. It is always asked. If I come as an examiner, I always ask this. Okay. Base of the triangle is formed by region of the mandibular third molar inferiorly. Apex is formed by maxillary tuberosity superiorly. Laterally, it is formed by the buccal mucosa. Medially, it is the anterior tonsillar. So this is the boundary of RMT. The beauty is RMT is the only pass where mucosa submucosa lies directly on the periosteum of the mandible where the inferior alveolar canal is there. Inferior alveolar. There is a small ala projection of the mandibular bone overlying the inferior alveolar canal, and chorda tympani nerve which runs there is directly on the periosteum. That's why marginal mandibulectomy is very tough to do in a RMT, even though it may be T1, T2, even though there may not be a erosion, because mucosa lesion is directly on the periosteum of the ala of the inferior alveolar canal and chorda tympani, and recurrence is very high if you try to do a marginal mandibulectomy. Okay, so this is an RMT and its significance. What is the most likely cause? Most likely cause of trismus recent onset in this patient is infratemporal fossa extension and involvement of the pterygoid muscle. Remember, there are only 2 structures in the head and neck. A muscle which is attached to both the jaw bones. Maxilla and upper alveolus is one jaw bone, mandible is low jaw bone. And that particular bone, one is buccinator, is attached to both, and second one is lateral pterygoid. It is attached to both jaw. You know that it is also attached to the angle, to the mandible. It is also attached to the lateral surface of the lateral pterygoid plate, which is part of palatine and maxillary junction, where the pterygopalatine fissure comes, inferior pterygopalatine. Okay, so the trismus cause is infratemporal fossa, and usually that initially was considered as one of the inoperable criteria. Now most of the time we operate that, but infratemporal fossa and skull base clearance is required. It has a very bad prognosis. It gets an access to the otic ganglion and all the structures, skull base and mandibular division and maxillary division of the nerve going into skull base. Now, what are the boundaries of the infratemporal fossa? Look at the photo I have kept. Make a picture in your mind. Now, I'll go back to the boundaries. It is a wedge-shaped area. It is deep to the masseter. Remember, masseter is on the outside of the ridge of the mandible. It is one among the strong muscles in the human body. Deep to masseter muscle and zygomatic arch. Laterally, the condyle process of ramus of the mandible. Medially, lateral pterygoid plate. Remember, both the pterygoid muscles are attached to lateral pterygoid plate, not to medial pterygoid. I always ask this question. Then what is attached to medial pterygoid? Always the students say medial pterygoid muscle. What is attached to lateral pterygoid plate? Students say lateral pterygoid. No. Both lateral and medial are attached to lateral pterygoid plate. It has got medial surface of lateral pterygoid plate, which is medial pterygoid. Lateral surface of lateral pterygoid muscle. Medial pterygoid plate has superior constrictor muscle, from which the pterygoid hamulus come, and median raphe is attached to the tuberosity, and then you have the styloid process and the apparatus, styloid apparatus and stylomandibular ligaments which separate the lingual salivary gland and the parotid, submandibular and the parotid. Read about it, okay? So it is attached to the lateral pterygoid plate only, and medially tensor velae pallatae, levator velae pallatae, superior constrictor. This is the medial boundary. Remember, tongue has intrinsic muscle, extrinsic muscle. All the intrinsic muscle is supplied by hypoglossus. All the extrinsic muscle is supplied by hypoglossal except tensor pallete, which is supplied by glossopharyngeal and vagus complex. Now, anteriorly, the infratemporal fossa is by the posterior border of the maxillary sinus, here on the back side. Posteriorly, the carotid sheath. So, the internal carotid goes and then the styloid apparatus is there. Roof is formed by greater wing of sphenoid muscle, butterflying muscle. And floor is formed by medial pterygoid muscle. Remember, medial pterygoid is attached to medial surface of lateral pterygoid plate and goes down and attaches itself into the angle of the mandible. Okay, so read about these things and what lateral pterygoid protrudes the mandible and what is the function of medial pterygoid. You read it. What helps in chewing. So this is an ITF boundary which is available. You must know. Then what are the types of marginal mandibulectomy? Coronal, oblique or L type, inner table, outer table, inferior or reverse. Okay, look at this. I have drawn all of them in the mandible. Coronal or oblique, inner table, outer table, reverse mandibulectomy, oblique or L type. Okay, oblique is done when ascending ramus has to be taken. Now, what are the absolute contraindication? Remember, the oral cancer doesn't spread in contiguity. It ascends up, goes through the pore of the dental. So, if there are teeth, usually it is a good resistance and a barrier. Edentulous mandible, it goes easily. You can't do. So, second thing is, if you are given a radiation, the general principle of marginal mandibulectomy is you must have 7 millimeter of the mandible. After you do a marginal resection, 6 to 7 millimeter of mandible should be left behind to prevent fracture, osteoidonecrosis, and you can put an osteo-integrated implant. The whole purpose of preserving the mandible or reconstructing with the fibular vascularized flap is to put an osteo-integrated implant for rehabilitation. Okay, so if you are given radiation before, it's not a contraindication. It is a contraindication. When you cut it, it may end up with a osteoidonecrosis. Then you may have to debride it. You may have to give hyperbaric oxygen. Second, edentulous. Old lady with no teeth. There is a resorption of mandible. The entry into the mandible is very easy because there are no teeth and the length is also very less. Second, even when there is no cortical invasion, cancer is on either side of the mandible. Floor mouth surface and also GB sulcus surface. And extensive paramandibular soft tissue. Even though mandible is not involved, if paramandibular soft tissue is involved on both the sides, if you try to strip it, you will leave a disease, it recurs. So these are the only absolute contraindication. Previous radiation, edentulous mandible, gloss mandibular erosion, cancer abetting on both surface of sides of the mandible, extensive paramandibular even in absence of erosion. I hope this part is clear. Now I'll go to next clinical scenario. The next clinical scenario is cancer cachexia syndrome. Look at this. Every cancer patient has a loss of weight. Loss of weight is not cancer cachexia syndrome. It is usually seen in ovarian cancer, stomach cancer. These are the two most common and also sometimes seen in esophagus, but more in gastric and ovarian. A patient with stomach cancer presented with more than 7% weight loss in the past 6 months. It reports that his food intake has been constant even while weight continues to reduce. He says, I'm eating, but it reduces. He has no GI tract symptom like vomiting, loose motion, or fever. What is the most likely reason for weight loss? Identify this condition, explain the pathogenesis of this condition, and what are the various nutritional screening tools you use in cancer for assessment, and how do you treat. See, like we say, performance status of the patient, Karnofsky score, WHO, ECOG. 70% and above Karnofsky score is required to do a curative esophagectomy and pancreatic surgery. 70. ECOG 1 and 0, 2 is better than you don't do any curative major surgeries. The only performance status used in pediatric oncology patient is Lenowski score. Okay, like that, what are the nutritional screening tools you use in cancer, and how do we treat this condition? Weight loss of 2% per week, more than 5% in 1 month, or 10% 6 months is called as cancer cachexia syndrome. Please read that, remember this. Week 2%, month 5%, 6 months 10%. It is characterized by systemic inflammation, anorexia, immunosuppression, metabolic derangement leading to unintentional, means you're eating, you don't have vomiting, you don't have loose motion, still you're losing, and there is failure to preserve the muscle and fat mass. What is the pathogenesis? Tumor necrosis factor, interleukin 1, interleukin 6, IFN. It leads to hypermetabolism, like something like what you have in hyperthyroidism, and to anorexia due to changes in the ghrelin, serotonin, leptin. Proteolysis induced factor and lipid mobilization factor contribute to loss of muscle and fat mass. Inefficient energy metabolism, insulin resistance leads to depletion. So this is the pathogenesis. What are the various nutrition screening things? This always I ask in exam. If you get CS cervix, rectal cancer, ovary. One is SGA, most common, subjective global assessment questionnaire. Next is NRS 2002. SGA and NRS 2002 are the most common nutritional assessment tool we use. You assess by dietary, medical, anthropometric, meets the tricep circumference, by biochemical indices like albumin, nutritional physical assessment. Then there is a CASCO score, that's called a cachexia score. 5 components: body weight loss, composition, inflammation, metabolic disturbance, physical performance, anorexia, quality of life. Then we have MNA score, then we have bioelectric impedance, also we have MUST score, MUST. How do you treat? Nutritional counseling, energy, protein, micronutrient, feeding schedules, some drugs called thalidomide, cannabinoids, omega-3 fatty acids. The most common drug used for management of cancer cachexia is progesterone. Remember this. Cancer patient in the terminal ill, they want to feel well and want an appetite to eat. They say, I just want to eat before I die. Then progesterone is the most common drug we use for cancer case syndrome. It gives a sense of well-being, puts water and you gain weight and you get desire to eat and your appetite comes back temporarily. So progesterone is the most common drug. I hope this particular is clear. Next clinical case I have made is an LABC, locally advanced breast cancer, which I'll cover now. A 32-year, young premenopausal lady. Remember this? Premenopausal. Para 1 leaving 1, 8 months of postpartum. It is a misnomer that if a cancer happens during pregnancy lactation, it has worse prognosis. No. For a stage to stage, for a IHC4 luminal HER2 same genomic profiling tumor, the locoregional control, overall survival outcome of a breast cancer during pregnancy and lactation is same as non-pregnant, non-lactating woman. Pregnancy and lactation make so many changes physiologically in the breast that it is difficult to identify the cancer early. So they present late and so they have a bad prognosis. Okay, in exam this is what you have to take. So young lady, 8 months after her delivery, noted a painless non-tender lump in the left branch since 2 months, rapidly progressing. No history of nipple retraction, discharge, bone pain, cough, breathlessness. On examination, she has a 5 to 4 centimeter lump occupying entire breast, erythema, erysipeloid rash-like feature on the breast, nipple area complex normal, axilla has 2 hard lymph nodes, the largest one is 2 into 1 centimeter, other breast is normal, systemic examination is normal. Look at this. Core biopsy was done, which showed it is a high grade, triple negative, high Ki67. Now, first question, identify this clinical condition. Those who see can clearly notify this is not a routine types of breast cancer. Can you see this? Not a routine type of breast cancer. Identify this clinical condition, define this condition, what are the common presentations and associated cancer, how do you treat this condition? Okay, look at this. This is, sorry, I missed this particular area. Okay. So the question that we need to know is, this is an inflammatory breast cancer. Okay, so this is an inflammatory breast cancer where there is no separate lump palpable within the breast. The whole breast is replaced. The whole breast is replaced by the mass. So when you palpate, you feel a browny edematous breast there is a erysipeloid rash. So this is not a locally T4B locally advanced breast cancer. T4B is different, T4D is different. So this is an inflammatory breast cancer, usually identified in a young woman premenopausal during lactation or during postpartum. No separate lump is felt. There is a diffuse erysipeloid rash. Breast and lump usually is not able to be separately seen. Okay, usually they are triple negative. They are BRCA1, BRCA2, HBOC positive. And as per the international consensus of inflammatory breast cancer, skin biopsy demonstrating dermal lymphatic invasion is mandatory. All the in case of inflammatory breast cancer, it is absolute contraindication for breast conservation. You have to do a mastectomy. Neoadjuvant chemotherapy in triple negative, we first do genomic assay, rule out whether their breast BRCA mutation or not, HBOC panel P53, P10. The neoadjuvant chemo, dose dense AC with Pacli. Even though Geopard trial says carboplatin has a better response, it is not a level 1 evidence in a upfront. It is used in a triple negative second line metastatic. After that, you do a modified radical mastectomy and a axillary lymph node clearance, because in inflammatory breast cancer and LABC, we don't do SLNB. And then if the patient is BRCA positive and if patient woman has completed her complete family life, do a laparoscopic bilateral salpingo-oophorectomy. And after the full chemo is over, no sandwich therapy, sequential, finish all the chemo. When you operate, there is a score called as RCB index, residual cancer burden index. If there is no pathological complete response, as per Createx trial, you give 6 months of oral capecitabine. Okay, and this is very, very important to understand this. But if it is HER2 positive, if RCB index is 2 or 3, no complete response, instead of trastuzumab, we switch over to TDM. I hope this part is very clear and I really want you to understand. I also have a slide. You must know what is a paraneoplastic syndrome. It arises from tumor secretion of hormones, peptides, cytokines, and commonest tumor, paraneoplastic syndrome is SIAD syndrome. That is small cell lung carcinoma, which is noted in mesothelioma, bladder cancer, thymoma, lymphoma. Hypercalcemia. Remember, in the breast cancer, you have osteolytic, osteoblastic, both. In prostate cancer, it is blastic. You also have osteosclerotic in multiple myeloma and also lytic. PET scan cannot identify non-lytic lesion. That's why PET scan is not a good modality to identify bone mats in breast, because osteoblastic it misses. That's why FTG 18, F18, PET bone scan is sensitive. Multiple myeloma, renal carcinoma, Cushing syndrome in small cell lung carcinoma, bronchial carcinoma, medullary CA thyroid. They are all cultured case scale, neuroendocrine tumors. Hypocalcemia happens in mesothelioma, lung cancer, GI cancer, sarcomas. How do we treat? In small cell lung carcinoma, CR, water fluid restriction, hypertonic saline. The drug is demeclocycline and conviaptan. Hypercalcemia, you give Lasix furosemide and you give bisphosphonates and hyaluronic acid. We not control calcitonin in 4 to 8 international units per kg, and then you also do hemodialysis. Cushing syndrome, ketoconazole antifungal is useful. Aminoglutamate, it induces medical adrenalectomy, and mitotane and mifeproston. For hypocalcemia, we give steroid, prednisolone, diazoxide, and we treat the underlying condition. The next condition will be a parotid tumor. A 53-year-old male presented with swelling in front of left ear since 7 months, rapidly growing. Remember, most of the parotid tumor are not rapidly growing, they're slowly growing. You know that they stay with pleomorphic adenoma for years together. Since 2 months, now last 1 month skin ulceration has happened. He also gave history of asymmetry of the face and inability to close his left eye. On examination, 4 into 3 centimeter hard fixed mass in front of the left ear and overlying skin. Ulceration is there. You can see that left-sided facial palsy. You must know, when you have a tongue cancer and there is a hypoglossal nerve palsy, tongue is protruded, deviated to same side opposite. You must know the mechanism. In facial nerve palsy, you must know the face is deviated opposite side or same side, and why this is pathology. This question is always asked in exam. Clinically, there are no neck lymph nodes palpable. Now, what is the most probable diagnosis under T status of this patient? What are the indications of neck dissection in malignant parotid tumor? And what is the indication of urgent radiation in malignant tumor? Next question. You can see that here radical parotidectomy. Remember, the most common surgery for benign tumor of parotid is superficial parotidectomy. The minimum surgery is superficial parotidectomy, even for benign. For the safety of the nerve, you have a Patty's plane, venous plane. There is anatomical parotid plane and surgical superficial lobe. Superficial lobe of parotid is anatomical and surgical. Surgical anatomical parotid is little deeper than the surgical lobe below the vein. So, for the sake of preserving the Patty's plane and the facial nerve, we always do surgical superficial parotidectomy of the superficial lobe, surgical super lobe, not anatomical. Okay. Now, the deep lobe of the parotid directly have a ducts outside the Stenson's ducts opening into the pharynx. That's why even if you leave deep lobe and remove the Stenson's duct, still you don't get parotid fistula because they directly drain into the pharynx. Okay. Now, the benign is superficial parotidectomy. In malignant parotid tumor where facial nerve palsy is not there, not invaded, the answer exam is total conservative parotidectomy. Means you remove both superficial deep lobe but preserve the nerve. Total conservative superficial parotidectomy. First you do superficial parotidectomy, pass a vascular loop and take all the nerves, go behind and remove the deep lobe. That is a superficial conservative total parotidectomy. What is the minimum surgery for malignant parotid tumor? Total conservative parotidectomy with or without neck nodes. I'll tell you. What is the minimum surgery for benign parotid lesion? Superficial parotidectomy. Here, it is a total radical parotidectomy, sacrificing the nerve, underlying masseter muscle, overlying skin, because it is an advanced lesion in this patient. Now you can see there is a cable graft that is kept to reconstruct facial nerve. So what are the donor nerves that can be used? And if you want to identify the facial nerve trunk intraoperatively, what are the landmarks? So 4 questions we'll answer. T status, neck dissection, when would you do? Adjuvant radiation, what are the facial nerve graft, anatomical landmark? Question 1. This is a T4A, skin involvement facial nerve palsy. Remember, in head and neck surgery, if there is a positive node, we do a comprehensive, curative, therapeutic neck dissection, level 1 to level 5. But there are, if it is N0 clinically and ultrasound and imaging, but if the chance of occult metastasis is more than 15%, as per the J.P. Shah textbook, you do elective neck dissection or staging neck dissection. Okay, remember this: elective neck dissection or staging when 15% chance of occult metastasis. You don't do level 5 in a oral cancer T1, T2 because the occult metastasis chance is less than 3%. That's why level 2B behind the nerve and level 5 is not routinely done in N0. Remember this point, okay? Now, if you have a tongue lesion, always the chance of occult metastasis is more than 15, so we don't leave the neck. We do a elective neck dissection. What are the neck dissections classified into? Elective and therapeutic. Elective or staging. SOHND, supra-omohyoid neck dissection for oral cancer N0. Lateral neck dissection 2, 3, 4 for pharynx, larynx. Posterolateral 2, 3, 4, 5 in scalp tumors and melanoma of the scalp or ear lesions. Anterolateral, okay, anterolateral neck dissection. Then you have central compartment in larynx, thyroid cancer and pharynx. Then you do superior mediastinal level 6 in case of thyroid cancer and thymic lesions. Okay, so you must know these are elective. Then you have MND 1, 2, 3, radical neck dissection, modified radical neck dissection, extended radical where you remove vessels, carotid, reconstruct all those things. Okay. Also, you must know who identified the levels of neck. Level 1, 2, 3, 4. You must also know who is the father who named the triangles of the neck. Submental triangle, digastric triangle, carotid triangle, Please know all these things. Who identified this? Who is Medina? What did Kryles do? What did Heinz Martin do? Okay, identify triangles of neck. Who devised it? Levels of neck nodes. Who devised it? Also, name of the flaps. PMMC flap by Aryan, Aryan. Forehead flap, nasolabial flap by McGregor. Deltopectoral by Bakamjian. So, like that, all the flaps, please identify who is the father. Remember, these are always asked in exam. Like I always say, Peridiox from France, Gustave Roussy is the guy who identified the TNM, and first it was done in tongue. Okay, Wang is the guy who did a TNM for nasal. So this is a malignant parotid tumor. So in head and neck, we do more than 15% occult metastasis, elective neck dissection. But there are two conditions. If there are no nodes palpable, no matter whatever be the T state, T4, T10, we don't do neck dissection. One is malignant parotid tumor, we don't do it if there are nodes, even it may be T4. Same with paranasal sinus tumors and hard pellet tumors. Even there may be T4, the chance of occult metastasis is less than 5%. Okay, that's why this question. When you have a malignant parotid tumor, what would you do? Remember, in the parotid, mucoepidermal carcinoma is the most common malignant. 75% of tumor are benign, pleomorphic. 20 to 25 are malignant. Of the malignant, most common malignant is mucoepidermoid. But the most common malignant tumor in case of sublingual and submandibular is 50-50%. Mucoepidermoid, adenoid cystic. But in minor salivary gland tumor, 90% of them are adenoid cystic, which can be low grade, high grade, which can have lung mets, no lung mets, which can be CD117 positive, so you can give imatinib mesylate, and then they can have perineural invasion. So remember these things, okay? So in parotid, we don't do elective neck dissection even if it is T4. The only condition is when there are clinically positive node or it is a high grade tumor, we do SYHT. Now, what are the indication of radiation? A R0 low grade tumor, node negative, you don't have to do radiation. High grade tumor, T4, like this case, skin involvement, bone fixity, skull base involvement, pathologically positive nodes, and recurrent malignant. You operated a malignant tumor, cured, and comes back again. Then you go back and excise the like you do skull base surgery and parapharyngeal surgery. It is bulging on the tonsil. There you give a post surgery adjuvant radiation. Okay, high grade T4, pathological node positive, recurrent. Now the most common cable nerve graft you use is greater auricular nerve, sural nerve, hypoglossal nerve. Please remember this. What are the anatomical landmarks to identify facial nerve trunk? Stylomastoid foramen, tragal pointer, tympanomastoid suture, posterior belly of digastric, superior border of the posterior belly of digastric just before it inserts itself to the digastric groove of the mastoid is the most common. You open the sling, digastric has anterior posterior belly, the sling is on the hyoid. Omoid has got superior and inferior belly, the sling is on the IJV at the junction of level 3 and level 4. So you identify the digastric triangle, see the sling, follow the posterior belly. Posterior belly inserts itself into the digastric groove of the mastoid. Just before that, superior border, if you follow, the nerve trunk comes. They are the most commonest and easiest. Or retrograde, you find a marginal mandibular, or you find a lower buccal, and then you start tracing, it goes. That is done when there is a recurrent tumor and nothing is there. It is all frozen, then you take a nerve and go. These are the ways to identify in exam. Next clinical scenario, superior vena cava obstruction. Look at this patient. Engrossed veins in the neck and the chest. 63-year elderly man came to emergency department with dyspnea, facial nerve swelling, examination tachycardia, BP normal, saturation low, but improves with oxygen. That rules out tracheal compression and dilated veins and chest. Look at the MRI, how there is a superior sulcus. Superior sulcus means, there is a lesion in the sulcus of the upper lobe of lung overlying the superior vena cava and the azygos at the thoracic inlet, going from neck to thorax to this is called a superior sulcus tumor. MRI with contrast of the same patient. Identify this emergency clinical condition. How do you define this? What is the most common etiology? How do you treat this? Superior vena cava syndrome present with dyspnea, most common, and other symptom could be facial swelling, head fullness, arm swelling, cough, chest pain, and brachial pain and dysphagia. It is condition where obstruction to flow through superior vena cava happens, commonly manifestation of primary tumor or a metastatic from extensive compression, like fibromatosis could be there, or there could be desmoid, or there is a thrombosis within the SVC secondary to the malignancy and hypercoagulation. What are the most common? Non-small cell lung carcinoma and lung carcinoma is the most common. Next is non-Hodgkin lymphoma in young patient. Hodgkin is very rare. It doesn't cause non-Hodgkin. So if you have an SVC obstruction with a lymphoma with the mediastinal node, remember it could be large B cell NHL. Or malignant thymoma, mediastinal germ cell tumor, mesothelioma, and solid tumor in the mediastinal lymph node in breast cancer. Non-malignant could be thrombosis, fibrosis, mediastinitis. Post-radiation can also cause. So these are the causes. How do you treat? Accurate history to see primary, secondary. What are the etiology? Glucocorticoids, loop diuretics, anticoagulant, thrombolytic emergency, stabilization of the patient. Endovascular stent to open so patient improves. Supportive care, elevation of head and head of the bed, supplement oxygen. Then treat the primary condition, which could be chemotherapy, or it could be NHL, germ cell, whatever you want to do, and then supportive treatment. Okay, so these are the issue I want to know. Next case capsule I have put is thyroid. It's very common, you know that. So history is a 25-year unmarried girl, young lady, presented with complaints of painless swelling in the right lateral aspects of the neck since last 3 months, which is gradually increasing in size. She does not give history of any cough, fever, breathlessness, loss of weight, bone pain. Clinically, she is euthyroid. On examination, 3 into 2 centimeter level 3 node, 1 into 2 centimeter level 4 palpable, no other swelling, and look at this particular node. Okay. When you look the CT, look at the CT, both thyroid. CT scan shows multiple lesion in both lobes. You can see that multiple lesion. Look at this 1, 2, 3. All of them is there. Then we have a level 2 and 3 node. And in the specimen, you can see multicentric lesion 1, 2, 3, 4, 5, 6, 7, 8. So multiple. Questions. This patient underwent total thyroidectomy with right functional neck dissection. Remember in exam, MND3 means you preserve all the three structure. The spinal accessory now, IJV and sternocleidomastoid. That is not synonymous with functional neck dissection you do in thyroid cancer. FND in modern era is not acceptable for squamous cell carcinoma of the oral cancer. You cannot do functional neck dissection in squamous CA. It is only reserved for thyroid cancer. In addition to these three structures, you preserve auricular nerve, you preserve all the muscles, you preserve the fascia, you preserve the ansa cervicalis. It is more functional. So functional neck dissection is more than MND3. So this patient history was, papillary CA thyroid, T3A, N1B. Remember, there is no N2, N3, N1A, central compartment, N1B is lateral neck nodes. 2 metastatic lung nodules seen on adjuvant iodine scan. Now patient is planned for RIA. What is the AJCC staging? What is the minimum TSH level required before doing a RIA if you are not using recombinant thyrogen TSH? What is the total cumulative radioiodine patient we can give in one time lifetime? This is a very important question in exam. What are the options available for management of iodine resistant well differentiated thyroid cancer? And 2 syndrome associated with medullary CA thyroid. And in addition to serum calcitonin, what are the other tumor marker? Very important question. I am answering this. Based on the CT scan, there is a multicentricity, so that is papillary CA thyroid. This, remember, one of the few cancers in the human body where age is used for staging is CA thyroid. Less than 40-year-old, there is only stage 1, stage 2, even if there is lung, liver, brain mets. Tumor marker is used in staging in germ cell tumor and testicular. All cancers have stage 1 to stage 4, but if you see nephroblastoma, Wilms tumor, there is a stage 5, which is bilateral. All cancers, higher stage has bad prognosis, stage 2 better than 1, stage 3 better than 2. Exception is Wilms tumor, stage 5 is bilateral, it has got better prognosis than stage 3, 4. And then hepatoblastoma, stage 2 is post-neoadjuvant chemo. It has got better prognosis than stage 1. So these are the only exception. Remember this in exam, okay? So AJCC stage, in spite of lung metastasis, since the patient is young, 35 year, it is only stage 2. The minimum level of TSH that is required before giving therapeutic is 25 mu per liter. Total cumulative radioiodine dose you can give in one human being's life is 800 to 1000 millicuries. Remember, this is always asked. To do a diagnostic iodine scan, we don't use radioiodine, we use technetium. So to prevent stunning effect, then we use a iodine. T3 has got a short half life, so you can use it for preparation. T4 has got long half life, 6 weeks. So what are the options available for iodine resistance? Lenvatinib, sorafenib, that is the oral tyrosine kinase. We can give retinoids, very toxic, or systemic chemo, adriamycin. And now nivolumab and other things are also used. Name any two syndromes with MTC, MEN2A2B, Sipples, and familial medullary carcinoma. In addition to calcitonin, serum CA is in very high thousands. Remember, CA is raised in colorectal cancer, medullary CA thyroid, also in lung cancers. These are the three tumors which you must learn. Next clinical scenario is tumor lysis syndrome. Middle-aged lady recently diagnosed with non-Hodgkin lymphoma, completed a chemo 3 days back, presented to emergency with 5 to 6 episodes of vomiting, muscle cramp, weakness, also one seizure. Total count is, see that? It is not low, high. That's very important. Post chemo count is low, but here high. Potassium high, hyperkalemia. Calcium hypo, 6.3. Uric acid high, phosphate high. ECG TTT, it is called tall tented T wave, peak T wave, short QT interval, QRS count, bundle block. Identify this emergency condition, define this condition, what are the causes for this condition, how do you prevent this, how do you treat. It is called tumor lysis syndrome. It is a constellation of metabolic disturbances that occur by rapid death of large amount of cancer cells by chemo, releasing intracellular ion and metabolic byproduct to systemic circulation, characterized by life-threatening lactic acidosis, hyperuricemia, hyperkalemia. Most common cause is hematological malignancies, acute leukemia. Remember, chloromas, testicular deposit is more common in leukemia, painful bilateral testicular. Second is lymphoma. Okay, because primary testicular malignancy are painless, absence of testicular sensation is there. But secondary, from hematological condition, leukemia, lymphoma are very, very painful. So acute leukemia with also chloroma can happen, deposits retroorbital, and it can protrude the eye. The difference between eye change, proptosis and eye protrusion, which is in thyrotoxicosis, active is different. Proptosis is a passive orbital tumor pushing, and active because of the muscles in thyrotoxicosis. You must know the difference. So most common cause of tumor lysis syndrome is leukemia, non-Hodgkin's high-grade lymphoma, myeloproliferative disorder, also pediatric cancers like neuroblastoma, hepatoblastoma. Identification of individuals at risk who has got large volume of cancer. Suddenly you dies and it lyses and comes with this problem. Look for that volume, and then elevated LDH, uric acid, creatinine before surgery. How to prevent this? Hydrate the patient well before giving chemo, give allopurinol and metabolic monitoring. Treatment, raspberry case, it's a recombinant urate oxidase. Management of hyperkalemia by calcium gluconate, insulin drip, sodium bicarbonate, dextrose. Hypocalcemia by calcium gluconate. Hyperphosphaemia by forced diuresis and mannitol and furosemide. Hyperuricemia by allopurinol and xanthine oxidase inhibitor and IV saline. So this actually, concludes my presentation. So there are a lot of scenarios, but I thought that this would help you to cover the whole thing. I'll stop sharing this. Now what I will do is I will try to take some of the questions which is available. So dimpling and tethering, how to explain clinically? It is a direct in continuity extension of the tumor to not epidermis but dermis. So remember, normal tethering and other things is because of Cooper's ligament. If the tumor is deep seated, But if the tumor is directly close to skin, direct continuity involvement. But as long as epidermis is not involved, it is not T4. So if the tumor is away from the skin, still there is a dimpling tethering, it is ligament of Cooper. But if the tumor is less than 5 millimeter of the skin and it is tethered, it is a direct extension of the subcutaneous tissue and not epidermis but dermis. What is persistent positive margin? What is persistent? How you? Yeah, the current answer is 2 times. If you revise the margin in breast conservation, it comes positive. It is meant as persistent positive. That suggests that the volume of disease is more than what is seen and felt. It happens in young dense breast with DCIS with lobular carcinoma. What appears as the tumor is less, but if you do an MRI, the volume of disease and microcal is much more. So you keep revising, the margin is more. So more than 2 times revision is positive. That suggests the volume of disease is under evaluated by you. It is much more. It is in DCIS, young woman, dense breast, and also it can happen in triple negative and woman and lady who has got a extensive DCIS. Then you convert to mastectomy. Difference between TNBC basal cell, both are totally different. Basal cell is a NGS. You to identify triple negative, you need to just do IHC4. But for basal cell, you need a next generation sequencing to do that. Which classification is standard for trismus and grading? You can use Indian classification. Either one of them are fine. Grade 1, grade 2, grade 3, you can say. 1 centimeter. Yeah, the answer, if you see Ramon Tiwari and this 11 millimeter is the ideal. You can say 10 millimeter. Nobody is going to fail you for 1 millimeter. The leftover mandible should be 6 to 7 millimeter. In inflammatory breast cancer, we cannot able to get a positive core biopsy. Yeah, you can do that. In inflammatory breast cancer, image guided, ultrasound guided core biopsy can get it. If you do blind, you will just get edema. Relation of OC pills and HRT use. As of today, there is no trial which shows that OC pills and HRT increases breast cancer. Remember this. There is no trial. There is no proof. So it is not. But it increases angina, osteoporosis, and cardiovascular events and stroke. As of now, the answer is OC pills, HRT is not directly being correlated to the breast cancer. Clinically, skin non-pinchable is taken as T4. No. Only T4 is satellite nodule, skin ulceration, pretty orange. Rest is not T4. That's very, very important to understand. Okay, this part I already answered. What is persistent OC pills? Everything answered. Okay, let me go to chat and see what are the questions. Okay, yeah. How do you measure breast size and cup size? There are cups which you are measure it. There are standard cup size. You can use a calipers or there is a cup, cup A, cup B, which comes. Sizers which you can measure. The best thing is also you there are pre-filled bra. You make a woman wear those measurement bra and you can also measure it. How do you measurement dimension of an ulcer in the oral cavity? With a scale. You can take a scale or you can take an instrument and then the graduation you can do that, or you can take a thread and you can then expand it. OCP I already answered. What is RX index? Please read about it. You must know in endopredict what score is high risk. In can assist what score is highest. What is RS? Please read about it. What is the recurrence index in RX? And then now, as per the new trial, they have reduced the intermediate score. What is low risk, intermediate, and high? Need of doing in cranial examination head and neck, is it mandatory? You just mentioned that you did a cranial now, but the relevant cranial examination, if you are at a node, then you must look at the palatal reflex. So you must look at vagus, glossopharyngeal, spinal accessory, and relevant thing is very important. If it is not, you did the cranial examination done normal. What should be the indication, contraindication for lateral neck dissection in CA buccal mucosa? T1, T2 buccal mucosa, well differentiated. Options are sentinel lymph node as per the new trial or SOHND. And you don't do level 4 below SOHND in a T1, T2 well differentiated. In buccal mucosa, T4 lesion, recurrent lesion, positive node at level 1 to level 2, then lateral neck dissection is added. Sir, shall our practical exam? Wait for the announcement. What is rapid growth of swelling defined as? What is the growth which happened in 6 to 8 weeks suddenly, which changed the dimension in 6 to 8 weeks is defined as rapidly. That is either a bleeding into the tumor or a high grade lesion. How do you clinically determine pectoral fascia involvement? There are two ways. One is by putting both the plasma into contraction. Look at this, both plasma. The plasma is the only muscle where it is attached on one side to lower end of the mandible. Lower end is not attached to bone, but it is attached to the faciocutaneous plane. Both the plasma continues down on the clavicle as a pectoral fascia. So if you put both the, like I'm seeing, see this plasma of the neck, then the fascia alone is put into contraction. You can also tell them to press the chin when you put both sternocleidomastoid. The pectoral fascia also gets. It's written in the book. You can read. Breast core needle by palpation. Always image guided. However, if you have a financial problem, you can try by a blind technique. But if it is negative, then refer for ultrasound guided. Ultrasound guided has 97% chance of positivity. Blind has got less. Even if we palpable less, there could be necrosis. UK Million study says breast cancer increased. No, we can't quote them. You can say that there is a trend, but it is not a level 1 evidence. How to mention plane of the swelling in the neck? Yeah, you must mention, below the plasma, above the plasma, below the sternocleidomastoid, above the sternocleidomastoid. First plane is plasma. Second plane is below the investing layer of cervical fascia. Remember, the investing layer of cervical fascia starts from the lower end of mandible. It comes down. It divides anteriorly into prelaryngeal, pretracheal, engulfs the thyroid, then the hyoid, and then the Burns lymph nodes. Laterally, it splits itself to engulf the carotid sheath, then the sternocleidomastoid muscle, and then the trapezius. It comes down, it joins below the thyroid gland, and then anastomoses itself deeply into the tunica adventitia of the right brachiocephalic vein. This is the anatomy. So you have to comment deep to the sternocleidomastoid muscle, deep to investing layer of cervical fascia or superficial, then plasma. These are the 3 planes you must comment. Contralateral neck dissection. Yes, I told you the same rule apply. Any lesion touching the midline, anterior, any lesion of base tongue, or any lesion where 15% chance of occult metastasis on the other side. So tongue, base tongue lesion with unilateral neck node, then the chance in the contralateral is 15%. Lesion touching midline, yes. Lesion touching base tongue and pharynx, yes. Or multiple N2 node positivity, opposite side node has 15%, you need to cover. These are the 4 conditions. Contralateral neck dissection can be contralateral SOHND or radiation to the opposite side. In a N0 node, neck, radiation and neck dissection has the same control. The moment it is a positive node, N plus N2, radiation is inferior in control, then surgical clearance and EBRT is important. Good. I think we covered everything very much, and also time is up. Anyhow, I just wanted you to cover the practical aspects. A lot of practical I covered. In coming time, we'll try to take more cases, maybe cervix, rectum relevant to clinical part. So thank you very much, and all the best for your exams. On the WhatsApp group of DNB, can you please leave the suggestion next coming classes of the month? What do you want to cover? How do you want me to take? What topics you want to cover? Please give me suggestion, and we will plan like that. Thank you very much. Over to you, Navneet Singh ji.
Yeah, thank you very much, Professor Dr. Somashekhar, for the presentation, and thank you very much, trainees and faculty members, for joining.